All right. Good evening, everyone. Thank you so much for joining us on the call this evening. For anybody that doesn't know me, I'm Rachel Narwald. I'm the senior nurse practitioner in the preventive cardiology team, also part of the Women's Heart Health at Lenox Hill Hospital. And we are so fortunate tonight to have Dr. Christopher Tanayan with us. And he's going to be talking about a very interesting topic, exercise. So at any point, if you guys have questions, I want you to feel free to put them in the chat box, and he will field questions at the end of his talk. So anything that pops up, go ahead and put it in there, and I'll keep track of the questions, and we can have a really nice discussion at the end. But he is going to be giving us a great talk this evening. I know our patients have questions so often about exercise, and we really haven't had a specialist at Lenox Hill, really, or in Northwell that can, kind of guide us with this. So Dr. Tanayan is almost coming up to a year, where I guess about 9 months since he joined the team. He is a non-invasive cardiologist and the director of sports cardiology, and is joining us at Lenox Hill Hospital. So we're so fortunate to have him. So Dr. Tanayan, without further ado, please take it away.
Thanks, Rachel. Hi, everyone. I'd like to talk to you about this really great topic that I think everyone should be aware about, and it's about exercise. And you may have heard several issues about exercise, whether there's the right dose, or is there anything that we should be worried about if you have underlying heart conditions. We'll go through those topics in this talk. So thanks for having me, and let's just dive right in. And I want to start with this event that in the world of sports cardiology, I don't think anyone will start a talk without mentioning what happened with Damar Hamlin earlier this year, right at the turn of the year, when he collided with T. Higgins during that infamous NFL game. Very early on in the game, he stood up after they tackled, when he was tackled, and he actually tackled T. Higgins, and he fell, and he stood up, and all of a sudden, again, he collapsed after a brief moment. And there is a consensus amongst cardiologists of, if he didn't have any underlying heart condition, or even if he did have an underlying heart condition, what happened was probably what we call commotio cordis. You may have heard this already before, and it is Latin for agitation of the heart. And the mechanism of that is when you suddenly introduce pressure in the intracardiac, or the pressure in the cavity of the heart, at a very specific moment in time. As you can see here, this is a heartbeat. This is a representation of a heartbeat in an ECG strip. And at this point in time, when the heart is resetting, so when you have a contraction, your heart should also relax to accommodate blood. At that very moment in time, right there in that window, is what we call the commotio cordis risk window, when the heart is vulnerable into changes in pressure. And as you can see here, here's a ball that suddenly introduces that pressure by hitting the chest wall. So your heart's beating normally down here, and when it hits that moment, that chest wall at that specific moment in time, you get a sudden surge in pressure that stretches out. This is what we think is happening. It stretches out the cell membrane and allows for potassium, particularly potassium ions, to flux in to the cell, creating a disarray in the electrical stability of the cell membrane, causing this wavelet of electricity to form that degenerates subsequently to an unstable heart rhythm called ventricular fibrillation, or VF. And as you can see here, normal heartbeat, normal heartbeat, normal heartbeat. And at that moment in time, when you get that disarray, you go into this an abnormal rhythm that does not support any cardiac output, which is what's important, of course, for the brain and the rest of the body to receive blood. And as we know, sudden cardiac death does not happen just in athletes or athletic individuals, but if they do happen in athletes, they get more media attention, precisely because we think that cardiac athletes are supposedly cardiac their cardiac fitness are supposedly high. And as you can see, those were older reports, but after Damar Hamlin's incident, I looked it up, and there actually were even more reports of young individuals who had sudden cardiac arrest on the field, and unfortunately, they have passed because no one was able to administer CPR right there and then, unlike with Damar Hamlin, when of course it was a televised event. There were 150 million people watching. There were tons of medical personnel on the field that were able to address his issue right away and save his life. Now, I want to talk about the definition of a highly active individual or athletic individual. So athletic individuals or highly active individuals are those who regularly and intentionally engage in physical activity beyond the activities of daily living. These could be the weekend warriors, when you have weekends that you do a lot of exercise because you have the time, and then just do less during the week because you have work. The leisure sports players who regularly engage in sports. Tactical athletes who participate in professions that require daily high activity, like firefighters, police, the military. And the definition of the athlete, based on the 1984 Bethesda Conference, the 16th Bethesda Conference, is someone who participates regularly in an organized or individual sport competition that puts high premium on excellence and achievement, and usually will have a very systematic and intense training regimen. When we study sudden cardiac death in athletes, it becomes very challenging because the precision of the studies and the results is difficult to achieve, given that the population that we are studying is very small compared to the rest of the world. And if you observe here, this is a very heavy, dense slide, but I'm just going to point out here the incidence of sudden cardiac death in athletes have varied significantly, but the estimate overall is about 1:50,000. It is rare, but it happens. And just as because I said that the precision is difficult in studying sudden cardiac death in athletes, if you look at all these pie charts, the distribution, although there are similarities in their contents, the variation in the size of the pies is quite big. Let's focus on the NCAA athletes, and these are all the causes of sudden death in this group. And as you can see, 15% of the causes of sudden death is cardiac. And this is the breakdown of all those cardiac conditions that cause sudden death. And if you look at this diagram, you can see that there are moving icons and there are stationary icons. The moving icons obviously represent the deaths that happen during exertion or during play. And you can see their commotio cordis has been counted. And if you look at just the pie chart here, the usual thing that we see are hypertrophic cardiomyopathy or HCM, some cardiomyopathies, other cardiomyopathies, coronary artery disease, myocarditis, anomalous coronary arteries, and this is sudden unknown death. And if you notice, these conditions are actually things that we see, like particularly coronary artery disease, the risk for this condition increases with age. Now, pivoting to the other aspect of exercise, that just gives exercise a really bad reputation because they can cause sudden death. But we know that exercise is medicine, and the very first study that actually kind of showed this is this study from the 1950s, when a group of investigators looked at the difference between the incidence of sudden death and myocardial infarction in conductors, in bus conductors and bus drivers in London. This is the London bus study. And obviously, if you think about it, when someone is working, if a bus driver and a bus conductor is working, the bus driver sits all day, while conductor is required to move around the bus, go up and down the steps to get tickets, etc. And look at the difference in the sudden death incidence between the conductors and the drivers. There's a significantly lower incidence in conductors than drivers, which makes you think about what is the key between the two. So exertion. Now, the Hazda population, which is a hunter-gatherer tribe, one of the few ones remaining in the world. If you look at their moderate to vigorous physical activity in a day, they are significantly more active than the average American male and female. As you can see here, they're way up in this chart where you have here the minutes per day, and that is across one's lifetime. So regardless of the age, whether they're young or old, they're much more active. And when we studied the incidence of hypertension or high blood pressure in this group, you can see that across the age groups, the Hazda population had a significantly lower blood pressure and essentially better blood pressure profile than the Americans that were included in the N-Haynes study, which is the bars in blue. And if you look at their cholesterol profile, the urbanized humans, modern humans, have much higher cholesterol than the hunter-gathering tribes and even the rest of the mammalian population. So they have a better cholesterol profile. And then the biggest difference is they were more active. And it's not just it's not just high blood pressure and cholesterol. As you can see here, the other medical conditions risks are also decreased with more exercise. You can see diabetes, fractures, obviously heart disease and stroke, psychological disorders like depression, dementia, certain types of cancers. They are all reduced by being more active. So exercise benefits you in more ways than one. This is a collection of all the high quality studies that have been performed that looked at the risk of all-cause mortality, the association of all-cause mortality to hours of exercise per week. And because of all these studies, this is what led to the recommendation of doing 150 minutes of moderate intensity exercise and 75 minutes of vigorous intensity exercise by the ACCHA. And essentially, this is what this followed throughout the world. And if you can see here, the largest drop in the mortality risk happens when you just get off the couch. When you start moving, you see that largest drop in mortality or death risk. Now, I mentioned the intensity of 150 minutes of moderate and 75 minutes of vigorous intensity as what we recommend to all our patients. Now, how do we know what is moderate and what is high intensity or vigorous intensity? So I'll just talk about, the common activities that constitute low intensity, which is no sweat. You can just walk, do light household chores, and that's low intensity. And these are other examples of activities that are low intensity. Moderate intensity are typically activities that allow you to talk but not sing. So walking briskly, raking the yard, and some types of sports are moderate intensity. And the vigorous or high intensity activities are those activities that only allow you to say a few words at a time, and you just need to catch your breath after that, just like most sports, jogging, running, or high intensity interval training. Obviously, it's already in the term. And obviously, these are subjective measures of exercise. They're based on MET levels, or metabolic equivalent of task. And there are more objective ways of finding how much energy you're actually consuming for each task. But we'll not go into that detail for now, but just know that this is how we classify intensity of exercise. Now, in this illustration, you can see the measured cardiorespiratory fitness and its relation to mortality risk. As you go from low cardiorespiratory fitness to high cardiorespiratory fitness, you see the mortality risk for men and women go down. And how do you improve your cardiorespiratory fitness? It is by exercise training. And if you own one of these wearable devices, they typically give you an estimate of your cardiorespiratory fitness level. And you may track this if you're training. If you want to see your exercise capacity improve, you can track this. I must say, obviously take it with a grain of salt, because this is something that's not individualized, but it can serve as a guide. And you can ask your providers in guiding you as to what these numbers mean in your wearable devices. Now, I want to go into the details of the benefits of exercise in certain objective data, like, for example, your lipids or cholesterol levels. We know that HDL is the good cholesterol that we want to be greater than 40 milligrams per deciliter, because lower than that, we think may be a risk for heart disease. And based on this study by Duncan, it looks like that, I just summarized it here, that when you walk at an aerobic pace at 11 miles per week, you may be able to achieve a 4 to 6% increase in your good cholesterol levels. And then the bad cholesterol, as we know, the LDL, we always target it to be less than 100 milligrams per deciliter. And that in this study in particular, they've demonstrated that if you walk for at least 10-minute bouts, you will be able to achieve 6 to 8% decrease in your bad cholesterol levels. Now, blood pressure, I just showed here a demonstration just so for those who are not familiar with what the upper number shows, what the lower number means. This is the normal blood pressure, 120/80. The 120 represents systolic blood pressure, and that is the pressure that's measured when your heart is contracting, and that's in your arteries in the periphery, in your arms particularly. And the diastolic blood pressure represents the pressure that is in those arteries in the periphery during diastole, or the heart relaxation. And I just showed here, if you cut the arteries into its cross section, so if you have your artery as a tube, you look at it in half, this is a normal artery. And if we have muscles around that artery, and if they're vasoconstricted, meaning the muscles are contracting, this is what you see, and that makes blood pressure high. And if your arteries are dilated and it's relaxed, that essentially you'll get a lower pressure reading. And there are numerous studies that have shown that in high blood pressure and those who exercise who have high blood pressure, there are mechanisms that exercise produces vasodilation in the arteries, thereby lowering your blood pressure. 5 to 7 millimeters mercury up to 24 hours post an exercise session has been shown to occur. So if you do this 30 minutes a day, several days a week, I must say that it's probably acting as one other blood pressure medication, because other blood pressure medication also produces the same blood pressure lowering effect. And there are studies that have shown that high intensity interval training is as good as moderate continuous, like long jogging or long running, in terms of lowering blood pressure. Now, glucose metabolism, this is probably a little bit of a complicated slide, but what I want to show here is that when you intake glucose, it's absorbed in your gut, and it's actually processed by the liver under the influence of insulin that is secreted by the pancreas. And the liver processes that glucose, and when you exercise, your muscles will need glucose. So some of that will go to muscles, and then the rest will go to other body organs. What does exercise do in reducing or in improving glucose metabolism? So in type 2 diabetes, there is an increase in hepatic or liver glucagon action, which increases thereafter the fasting liver glucose. Exercise has a negative effect on insulin resistance in the liver, meaning the response of the liver to insulin. And exercise prevents resistance, so the sensitivity increases, thereby improving the blood glucose level during fasting. So it lowers blood glucose. And as you can see here, it reduces fasting glucose production. And another effect of exercise is in the muscle uptake of glucose. As you can see here, in type 2 diabetes, there's a decreased muscle glucose uptake. But if you exercise counteracts that and improves glucose uptake in your muscles. And if you can see here, there's IHL, that's the lipid level or lipid content of the liver. And then for body mass, we know that what you take in is, and what you burn in terms of calories determines if you have a positive body mass or a negative body mass. So if you want to have weight loss, you want to increase your calories burned. And if you want to gain weight, then you want to increase what you take in. And as you saw earlier, exercise is in the calories out portion. So the more you exercise, the more energy you burn. Obviously, you want to pair that with diet, because you don't want to counteract all the exercise that you do by eating more. And this has been shown in a large study by Dr. Krause in the early 2000s, that those who were inactive actually gained body mass after their study period. And those that did any type of level of exercise, low dose moderate, low dose vigorous, high dose vigorous, they all lost weight. Now, how little does it take? We discussed earlier the 150 minutes of moderate intensity exercise and 75 minutes of vigorous intensity exercise. This is a recent study that was published late last year that argues that even a very short bout of vigorous physical activity can produce a great reduction in all-cause mortality. As you can see here, 15 to 20 minutes per week of vigorous physical activity caused a significant decrease, about up to 24% of all-cause mortality reduction, with an optimal dose of 50 to 57 minutes per week. So if you are thinking about, I don't have enough time, then maybe do about 10 minutes of exercise, do that 5 to 6 times a week. And when I say high intensity, of course, you want to get to that point that you're actually getting tired and you're only able to speak a few words before you need to catch your breath. Obviously, you don't want to do that from 0 to 100. You don't want to do a 0 to 100 miles per hour kind of exercise. You always want to warm up and cool down. So doing a 10 minutes high intensity exercise with appropriate warm up and cool down would be enough to give you a good deal of benefit in terms of lowering your cost for risk for death. And as you can see down here, 2 bouts per day, up to 2 minutes, were associated already with a 35% lower cardiovascular disease mortality. So this is very good in terms of encouraging people to be able to do at least some form of exercise every day. And this was also interesting. I found also very recently published that morning physical activity was found to be a better time to do your exercise because of, as you can see here, lower 16% of coronary risk for coronary disease and 17% decrease in stroke risk. And this is on the UK Biobank registry. And as you can see, there's a ton of participants, over 80,000 participants in that study. Now, let's move on to what we call the exercise paradox. If you participate in fun runs, you would always see medical tents along the ways, particularly at the finish line. You can see, people dropping at the end of the race. We always have all these emergencies. And actually, a group of investigators actually studied this. Jonathan Kim and Aaron Baggish, they did this 10-year study on all the marathons and half marathons in the U.S. in the span of 10 years, and they looked at the incidence of sudden death during these events. And if you can see here, majority of these events, although the rate is very low, it's like 50 and 10 million participation over the course of 10 years. But they all happen, or most of them happen, towards the end of the race. And when they did autopsies and they did medical examination on those both who survived and did not survive that sudden cardiac arrest event, as you can see, there are underlying cardiac conditions in most of them. And those who survived mostly had myocardial ischemia. This is coronary disease when you have blockages in your arteries. And those who did not survive had what we call HCM, or hypertrophic cardiomyopathy, a culprit that we've already seen in those pie charts before in the study of sudden death in athletes. Now, how do we know if someone is at risk? If those people that participate in those races may or may not have known their underlying cardiac condition before they participated. Obviously, I think these are questions that are good to ask yourself or your family members, your friends who are planning to participate in high intensity activities like a marathon. Obviously, know personal history. If you have high blood pressure, heart conditions, you've been told you have a murmur, you have stents, you have devices in that power your heart. If you've had a history of stroke or TIAs or mini strokes, and if you have family history of heart conditions, sudden cardiac death or sudden deaths, restrictions from sports or intense exercise in the family. If you're on medications for blood pressure, cholesterol medications, blood thinners, diuretics, or what they call water pills, or what we call water pills, steroids, performance enhancing drugs, including the blue pill, I think those are things that need to kind of raise concern. If you get symptoms during or after exercise, like chest pain or discomfort, you get unusual breathlessness. Of course, if you're trying to exercise and you're at that high intensity, you have to catch your breath every few words. But if it's unusual at a very low intensity, then that you need to be concerned and bring it up. If you're feeling faint, if you're fainting with exercise or after exercise, if you feel irregular heartbeats and palpitations, like your heart's skipping out of your chest, if you feel anything atypical during exercise, like arm tingling, having visual disturbances, or throat tightness, something that's not usual for you when you exercise, then I think those are things that you need to bring up to your medical provider. Now, is there really too much exercise? And this is, exercise paradox. When you exercise, we've shown that you improve your lifespan, you increase your lifespan, and you reduce the risk for death. But also, you're at the highest risk of developing sudden cardiac arrest when you exercise, like what we showed earlier. And then there are these 4 other conditions that have been, questioned whether these are caused by exercise. And we'll go through each of them one by one. Let's start with coronary artery calcification. So coronary arteries are the arteries that come off of the big vessel that come off of the heart. When, of course, the heart pumps blood to the rest of the body, and it goes to this big artery called the aorta. And in the aorta, you have these coronary arteries. Interestingly, the heart doesn't get its oxygen from the blood it pumps. It gets it from these arteries that supply it with the oxygen it needs for the energy to pump blood. And when they get blocked, like so, if you cut that tube again into its cross section or half and look at it from the front, this is what you see. The lumen is right here. You get all of these buildup of cholesterol. And there are high risk types of cholesterol buildup or plaques. And they're prone to rupture. And when they rupture, they expose the inner contents, and these inner contents are very prone to clotting. So if the blood sees that, just like when you cut yourself or you nick yourself and you bleed, it dries off because your blood clots. It can clot, but then you don't want it clotting inside the blood vessel, because that will occlude that artery in supplying the heart with oxygen and the blood with oxygen. Now, when you treat that with, when you say we take statin medication or cholesterol medications, you kind of make it into a stable plaque or a stabilized plaque by calcifications. So when it's calcified, it's less likely to get ruptured to expose that inner content that's highly highly clots. And in a previous study, this was in 2017, just focus yourself here, athletes versus controls based on the color. As you can see, calcified plaques, the one that's less likely to rupture, are higher in athletes than in controls or non-athletes. And the mixed plaques, meaning those that are partially, some of them are calcified, some of them are not, there are more of those mixed plaques in the controls. However, this just came out recently, was published last month, and was presented in the recent conference of cardiology. It seems like there is truly that this kind of proportion of favorable plaque and non-favorable plaque is not the same in their study. If you can see here, there are three sets of people: those that are late onset endurance athletes, those that started exercise after the age of 30, the lifelong endurance athletes who have been exercising their whole lives, and those who are healthy, male, but they are all males participants. As you can see down here, there are more plaques in the lifelong athletes. And if you look at the plaque type, it seems like the lifelong athletes had more of the mixed type of plaque, and they have almost the same number of proportion of calcified plaques. But the mixed plaque, is not the same as the study over that happened in 2017. So my answer is coronary calcification caused by exercise. The answer is maybe. I think there are conflicting data out there, but both are we need to consider them both. Now, aortic dilation. Just going back on the anatomy of the heart, the aorta comes off of the heart, and it supplies the rest of the body with blood. Dilation is just the enlargement of that, and this is how it looks compared to the normal aorta. Now, there was a study that was published in 2017 that looked at former NFL players and the diameters of their aortas. And as you can see here, the average or the majority of them have a skewed number towards the higher number of 36 to 38 millimeters. Whereas those that were included in the Dallas Heart study, which are normal individuals, are kind of skewed towards the 34 to 32 range. So there's this is showing that essentially there's a bigger size of aorta in NFL players. And Is there too much exercise in this involved in this? Maybe. The explanation that we have for this is in NFL players who actually need to build muscle mass, they do a lot of heavy weightlifting. We know that heavy weightlifting entails pushing really heavy weights that make you strain a lot, and that kind of exercise actually increases your blood pressure during that moment of exercise. And if you do that frequently, that increased blood pressure that you impose on the aorta, essentially when your heart contracts against that pressure, it predisposes dilation in that part. So, but there's no clinical significance to this. There's no, they've not shown any kind of bad or worse outcomes in former NFL players compared to regular individuals. Another controversial issue is heart muscle scarring. And this is just the heart being cut into its long axis, and this is being cut into its short axis. So the right side of the heart is here, left side of the heart is here. Here it's the right side, left side. And in Andrei Lagrish's study, as you can see here, this is the MRI version of this one. So this is the left side and the right side. And they found that in the insertion points of the right ventricle into the left ventricle in these areas, there was scarring. And this is seen in MRIs. The explanation and to this is that when athletes or the long-term endurance athletes, this is a study on runners, when they looked at the hearts at baseline during the relaxation phase and the systolic phase or the contraction phase, and compared it with the way their heart looks after they exercise, after they finish a race, you can see that there is an increase in the volume, particularly in the right side of the heart. As you can see here, positive 13 mLs during that contraction phase and positive 9 mLs during that relaxation phase. Naturally, a smaller chamber during diastole or relaxation and during systole, which makes sense because as you can see here, the left side of the heart is a thicker chamber. So it's essentially stronger than the right side. So when you circulate blood during exercise, when you do a lot of running, endurance exercise, the right side becomes more strained and it dilates more because it is thinner. And that strain essentially may be the explanation why there are these scarring that occurs. So is this too much exercise? Maybe. Again, there's no clinical downside that has been found that's related to these scarring. So clinical importance, we don't know. And finally, atrial fibrillation. So I think the best study that represents the idea of too much exercise is the study on the Vasaloppet ski races in Sweden. So what they did here is that they looked at those that finished quicker and those and looked at the number of races the participants participated in. Those that finished quicker, which essentially represents the intensity of how they raced. So those who raced at a higher intensity finished faster. And those that raced more essentially has more exercise volume. And they found that in men, particularly, those that finished fastest and raced more, so higher intensity exercise and higher volume exercise, had an increased risk for developing atrial fibrillation, which is very convincing. You can see that there is a higher uptick here to the relative hazard, meaning that the risk for developing a fib, than those that finished the races slowly, which interestingly was not seen in women. In women, there's no difference in whether you finish fast or slow. So there's no signal to an increased AFib in women, at least in this very big study, over 50,000 participants. So I think of all the data, this is the most convincing that too much exercise, particularly in the high endurance athletes, there's a signal for increased risk for atrial fibrillation, and there's a mechanism that we found on why this is. But when they also looked at the outcomes, so comparing athletes, endurance athletes who have a fib and non-athletes who have a fib, looking at the outcomes, meaning development of stroke, development of heart failure, development of all these bad things that can happen to your heart and your body, the outcomes are better for those who are athletes or for those who exercise. So just in summary, coronary calcification, maybe, aortic dilatation, maybe, heart muscle scarring, maybe, but atrial fibrillation, a clearer yes answer, that there is probably too much exercise, may put you at risk for atrial fibrillation, but again, outcomes are better overall in athletes who develop a fib than those who are non-athletes. Now, when is exercise bad? There are three things that I can think of, particularly ARVC, which is, these are cardiac conditions that definitely, if you have this, you should talk to your cardiologist to ensure that you're doing the right thing in terms of exercise. ARVC is arrhythmogenic right ventricular cardiomyopathy. If you have untreated catecholaminergic ventricular tachycardia and laminopathy, which is a heart failure condition. So, but this is going to be a talk for a whole different session. Before we end, I just want to pitch again, sudden cardiac arrest can happen to anyone, anywhere, at any time. If you can see, this is the commotio cordis registry in Minnesota, the only one we have in the United States by Dr. Marin. And I just want to point out, you can see here, even the mundane things like, oh, sorry about that, someone being hit by a snowball or someone being kicked by a horse. These are things that you wouldn't expect to hit, a chest wall and, can cause commotio cordis. So hands only CPR is a big thing. Everyone I think should know how to do this because, and do this the right way. Like here, you need to use your weight to go and pump on the chest of someone. Don't buckle your elbows because you need to transmit your weight to the person's chest. This is the right hand position for that. And you have to depress enough, like you really have to go down at least 2 inches, almost feels like you're breaking someone's rib, and let it recoil before you pump again. You do this 100 times per minute at least. Don't forget to call for help before you start CPR, and it's okay not to do mouth to mouth. And these are good resources for that. These are good websites for that. So I think with that, I will end. And I thank you for your attention.
Thank you so much, Dr. Tanayan. That was fantastic. Such a great overview. I know when I was a student training, one of the attendings I was working with, he said, I'm never going to tell patients not to exercise unless they have one condition, and that was the ARVC. But he was like, every other thing, exercise is great. But I think that's a really sort of simplistic view. It's obviously so much more nuanced and complex, as I think you touched on really, really well tonight. And, a lot of our patients, let's say there's been an event, let's say there's been a new diagnosis, they're feeling very vulnerable, feeling very concerned about the safety of exercise, and about what's normal for them. And they may not have access to something like cardiac rehab, and they're feeling kind of very lost. So, one of the questions that we get a lot is, I feel like you did a really great job of showing sort of the warning signs that people should be aware of when they're exercising. Let's say it's a patient that really hasn't been actively exercising for an extended period of time and they're wanting to get into an exercise regimen. Would you say most people should maybe see their general practitioner, see a cardiologist, and just sort of have like a basic workup before embarking on a new exercise regimen?
I would say yes. And, those screening questions that I presented here are like good things to like go through in your mind if you're thinking about going to do an exercise program. Going through those things in your mind. Do you have these conditions? Do you have these symptoms with exercise? And if you're not sure, obviously talk to your physician and talk to someone who may be able to help you. And obviously, I definitely recommend exercise to all my patients, regardless of what condition you have. I think it's beneficial, obviously, except for the ARVC condition.
Yes.
because the other two are relative, so they're not absolute contraindications. But there is a way for you to be able to, increase your exercise capacity, your cardiorespiratory fitness, as I've shown earlier, as you get improvement in your cardiorespiratory fitness, your risk for mortality drops. And so I think everyone needs to keep that in mind. And there are heart rate zones that we can target, particularly if you have a cardiac condition. Depending on that cardiac condition, obviously, we'll tailor an exercise program that will be safe, and that you will be guided, and that, and then we can do testing before you actually do an intense exercise program. I think it will depend on what condition you have, on what kind of pre-exercise evaluation that needs to be done. But certainly talking to someone is the first step.
Yeah, absolutely. And, speaking of people using a lot more of these step counters or Apple Watches or what have you, we do have a question. What do you think about a step goal for the day? Whether it's 10,000 steps a day or, what would you tell patients about that?
So it was interesting. Someone did the math on this, Dr. Krause, when he was actually doing the stride study. He, looking for the right dose, the right exercise dose to achieve the benefits of exercise. And 10,000 was just it was a random number. It was because in the I believe 1970s, there was this Manpoke, which is it's a Japanese device that actually tracked steps, and it was during the Olympics at that time, and so it was a big fad. So everyone wanted to do some form of exercise, so they jumped on that, and eventually they found that if you actually use the exercise dose that has been found to be beneficial in studies and converted that to steps, it actually comes out to be around 10,000. So it actually is perfect. Set between 7,500 to 10,000, 7,500 steps, 10,000 steps is actually a good target. And it gives you a sense that, again, getting off the couch, you won't be able to reach 7,500 steps a day if you're sedentary. So that means if you reach that number of steps, you are actually doing something that is beyond the daily activities that, just going around the house, going to the bathroom and stuff. So going above that actually makes you an active person. So I think that number between 7,500 to 10,000 steps is a good number to target.
Absolutely. Agreed. I think that's great guidance. And, what do you think about, we get a lot of questions from patients about whether exercise is more beneficial if they're doing cardio, for example, using the treadmill, doing a bicycle, versus resistance training. What do you kind of guide with that?
So it's both. The answer is both, particularly when we get older. Cardiovascular exercise or endurance training improves your cardiorespiratory fitness overall, and we have a ton of data that support improving cardiorespiratory fitness will improve your mortality or your longevity. Now, the strength training part actually contributes in a way that it strengthens your bones. It makes you form bones. It makes you develop muscles. It makes your muscles and tendons that support the joints stronger and more prepared in doing activities of daily. So that reduces your risk for falling, reduces your risk for injuries, which essentially, if you think about it, also will help prolong your life because you are doing things that make you a safer person overall in terms of doing activities. So a combination of both endurance exercise or aerobic cardiovascular exercise and strength training is good.
Absolutely. And, I love that you pointed that out, because I think at some point, depending on your age, I know for me, when I was in my 20s, it was much more about vanity, or maybe I had a
Yeah.
goal to run a marathon, and as I've gotten older, it's much more about keeping my functional capacity, and keeping myself
Right.
safe. Because as you said, God forbid you have a fall and then there's a fracture, and, it can just be a slippery slope, pun intended, So
Correct.
I
Yes.
think kind of guiding people that it's about much more than just sort of, the obvious kind of benefits that we get from exercise, that it's preventative. And as you said, that it's medicine. I really like that you worded it that way. We definitely feel that way too. A little bit of a slightly different question, but listen, people are usually looking for a lot of different methods, if you will, to get activity in. What do you think about some of these more sort of fad things, where I have patients ask me about like being in a sauna, doing something that's going to sort of promote sweating or promote an elevated heart rate? There's like machines that you can use, or like UV treatments that they're saying is mimicking exercise. What would you tell patients about that?
That's a very good question. And I really like that you asked that question, because sweating is not equivalent to exercise. If you think about it, what we're trying to do when you're improving your cardiorespiratory fitness is training your heart to increase its rate, coupled with muscle function. And if you just increase your heart rate without that, you're leaving out the benefit of the adaptations that you create with exercise. So what happens is, when you exercise, when you train for a marathon, or you do increase your volume slowly but surely over time of doing endurance exercise, your muscles have adaptations, your vasculature have adaptations, your heart creates adaptations. So it changes with time during that exercise period. So if you have a more favorable structure and function and physiology in the muscles, in the blood vessels, in the heart and the lungs, you overall get that benefit. But if you're just sitting in a sauna and it increases your heart rate because you get dehydrated, because it's so hot, because you're, all those other things, you're leaving out the adaptations that actually make you benefit from the increased heart rate, but make you benefit from the cardiovascular training. So I must say, it doesn't equate to exercise. That's a short answer.
No, I think you explained that perfectly. I think that that's I could not have said it better myself. And I think that that's something that's important, is that patients understand sort of more of the subtleties, of what's happening. I think there's been a lot of sort of disservice done to the patient population, whether it's about exercise, but whether it's about taking a supplement that's going to give them all of their vitamins and minerals for the day. There's things physiologically going on in our body that we sort of can't get a shortcut for, so I think that's a big kind of takeaway there. Bringing another kind of pop culture thing, a question for you. You did such a great job of kind of highlighting with some of the sudden cardiac death in the sports world. I don't know if you remember, but there was a lot going on about Peloton bike. Do you remember this, sort of with the TV show where the guy had the heart attack and dropped dead after the
Yeah.
Peloton bike?
Mhm.
Is there something innately unsafe about Peloton? What do you think about that?
I must say, not innately wrong with Peloton itself. So, that's one of the, there are different definitions of the exercise paradox. And one of the more important one that I stress to my patients is that, exercise, if you do it every day, you extend your life longevity. But the paradox is, when you exercise and you are at that highest peak of your intensity, you start developing a physiology that's called when you reach your anaerobic threshold, you start developing lactic acid, you start becoming dehydrated, you deplete your glycogen stores. So these things create stress in the body. So at the peak, at the highest intensity of your exercise, you're actually putting yourself at the highest risk for cardiac events, particularly ischemia or arrhythmias. So that's the reason why those that had those sudden cardiac events during the end of their marathons and half marathons. That's why those events happen during that time. It's because they've already reached their their anaerobic threshold, they're bathing in lactate, they have been dehydrated, glycogen depleted, stress hormones shoot up during that time. And if you have an underlying cardiac condition, or you're at risk for developing a cardiac event, say you have unknown ischemia or unknown blockage that it's not discovered, you can have an event during that peak exercise moment. So it is of course scary, but that's why we're tailoring our exercise regimens for those who have underlying cardiac conditions. We want to modulate the risk. We want to understand the exercise physiology of each individual so that we can give them information as to where is it safe, what is the safe level of intensity for you, and that so that you don't put yourself at risk in developing these events. So that episode, I think that's one of the, it just happened, I think last year.
Yeah.
Obviously put exercise, in kind of like in a bad light, but then obviously we can't deny that it's true. There's that risk, but overall exercise is still beneficial if there's an overwhelmingly positive data for exercise and not against it.
Absolutely. And I think, as you said, kind of doing it under the guidance of a provider is always going to be beneficial there as well. If there's any concerns, I think we do have time for one more question, sort of in the same idea of the intensity. You mentioned the heart rate levels and things that can be tailored when people are working with a practitioner. But what do you feel, I think it was sort of popular at one time there to talk about this high intensity training, right? You could do exercise for 10 minutes to get the benefit of an hour, and then there's kind of this steady state idea where you're in the fat burning zone. What do you kind of think about the intensities there based on the benefits?
I think they're both types of exercise, the moderate continuous intensity exercise and the high intensity interval training exercises, they both actually provide you with benefit. And I think it just matters to which would make you more motivated to exercise, what is more interesting for you, which is more challenging for you, because some people get bored with running on a treadmill on a low to moderate intensity fat burning zone for like 45 minutes. They want to kind of mix it up and make it like something that changes every once in a while, and you get these, there are data, there's evidence out there that support high intensity interval training. Obviously you take a little bit more risk during those moments. Like I said, when you go up to your, beyond the anaerobic threshold, which we can get from a specific test that we do in the lab, you put yourself at risk during that moments in time. And if you go up and down from like a high intensity level, then you rest. That's good, because you gain adaptations during those moments of high intensity exercises, which you don't get from just staying steady state on like a long run, like long steady jog. So there are benefits to both. And I think if you want to just simplify it in your mind, I think whichever interests you, whichever would get you doing something, if you would be able to do more exercise with this kind of exercise than this, then go for it. Just do it. Just do something. You can't just sit on the couch all day.
Right. Yes. It's about movement. I think that's so true. As we say sometimes as providers, that the best medicine is the medicine the patients will take. I think it's the same thing, right? With exercise. What do you enjoy? Right? Yeah. What will get you off the couch? What will keep you coming back? And I think it's the same type of mindset where we guide people with nutrition, which is things in moderation. It's always good to have a variety. You want that resistance training. You want that sort of lower intensity, steady state. You want some times where you're getting up into that, moderate to vigorous intensity, because your body's going to adapt, and that's what we're telling people, that, if you're walking the same 3-mile loop every single day, your body is going to be like, oh, please, like, this is nothing. We've got to kind of continuously shock our body, if you will, to a safe level, where we're building in that variety and kind of not letting our bodies get too complacent, right? And too used to one type of activity.
And also, depending on the goals that you have for exercise, if you're someone who is training particularly for a marathon, If that's the goal, then the type of training is very different than if you're training to become better in playing tennis or playing some type of sport, because there are different exercises that will tailor for improvements in performance for a marathon, and improvements in performing a sport, or maybe some other type of activity. So it also depends on the end goal, and not just if your goal is to just increase your lifespan, do what you love, do
Yeah.
what you enjoy.
I love that. I think that's perfect advice and a perfect place to end. Sorry, everyone, we went a minute over. I just want to remind everybody that these lectures are recorded, that it will be on our YouTube channel. I put it in the chat, but it's Doc Heart Health. So feel free to reference this later, tell your friends, anybody that you think would benefit from this. Dr. Tanayan, I can't thank you enough. This was so, so helpful and so entertaining, and I think just so apropos for everyone. So we appreciate your expertise so much. So thank you. And thank you to everyone who joined tonight. And you know that I'm always available for questions, comments. Feel free to reach out. And thank you so much, Dr. Tanayan. I wish everyone
for having me.
And yeah, go out and exercise tomorrow, right?
Get out there.
Perfect. All right. Thank you so much, everybody. Take care.
Bye-bye.
Right. Thank you, Rachel.
Thank you, Monique.
Dr. Tanayan.
Thank you. I hope you learned something tonight.
Yes, it was so I always learn something from you, and it only helps me with my patients. So thank you so much. This was perfect.
Happy to be of help.
And thank you, Monique.
Yes, no problem. Have a good evening.
Have a good night.
Bye.
Bye.